Hello students, in continuation with our series of lectures in cardiology, today we will be looking at mitral regurgitation, right? So mitral regurgitation basically refers to the flow of blood from the mitral valve backwards into the left atrium because the mitral valve is incompetent. So let us just brush up on the structure of the mitral valve again and look at the various etiologies for mitral regurgitation. So as we all know, the mitral leaflets are two in number. It comprises of the anterior mitral leaflet and the posterior mitral leaflet, and they join together to form the commissure. This entire mitral leaflet is held together by a ring-like structure which is called as the annulus. Then can you see that there are some cord-like structures which are seen attached to the mitral valve? This is your chordae tendineae. And you have finger-like projections which occur from the LV, and this is the place where the chordae tendineae attaches to the LV, and this is called as the papillary muscle. So why we should be aware of the structure of the mitral valve is that if any of these areas are affected, so any pathology which affects the valves, which affects the annulus, which affects the chordae tendineae or the papillary muscles can result in mitral regurgitation. Okay, so now just look at the etiology. So, most importantly, the first etiology that you should know is that rheumatic etiology. So, MR can be associated with rheumatic fever, infective endocarditis. In infective endocarditis, there can be erosion of the chordae tendineae, or there can be rupture of the valves as well. So, that can result in MR. Papillary muscle. So, the most common papillary muscle which is involved is your posteromedial papillary muscle. So, the most common papillary muscle that is involved is your posteromedial papillary muscle, which is associated with an inferior wall myocardial infarction. So, rupture of the papillary muscle, what happens is that, can you see here, the papillary muscle is attached to the chordae tendineae, which is then attached to the leaflet. Now, if the rupture happens and the chordae tendineae, if the papillary muscle itself is ruptured, the chordae tendineae also becomes flat and the leaflet becomes pale. So, if the leaflet becomes pale, the blood moves backwards, so it results in regurgitation. Post-surgery, especially when you do a percutaneous balloon mitral valvotomy for MS, if you go too much deep, there can be rupture of the valve leaflets and there can be MR. Apart from that, there can be secondary MR. What happens in dilated cardiomyopathy? In dilated cardiomyopathy and ischemic cardiomyopathy, this is your LV. So, suppose this is your LV cavity and this is your annulus. It is snugly fit into this LV cavity. But if the LV cavity dilates because of dilated cardiomyopathy, the annulus also dilates. So, if the annulus also dilates, then what happens? The mitral valves cannot coapt properly. If they cannot coapt properly, then the blood again regurgitates. So, these are the various etiologies for mitral regurgitation. Now, let us look at the hemodynamics of mitral regurgitation. So, mitral regurgitation can be acute as well as chronic. So, when do you get an acute mitral regurgitation? You can get it with infective endocarditis, you can get it with trauma, or you can get it with papillary muscle rupture like post myocardial infarction. So, let us understand the hemodynamics of acute mitral regurgitation. Now, secondary to any of these causes that we have discussed, there is a acute mitral regurgitation. This is your LA, this is your LV, this is your aorta. So, what happens when the huge amount of LV blood regurgitates back into the LA? The LA was not prepared for this, right? So, the LA is non-compliant. So, the LA is non-compliant. So, there is a sudden rise of pressure in the non-compliant LA. In a non-compliant LA, there is a sudden rise of pressure because of this regurgitation. So, what happens? The patient deteriorates very rapidly. So, the patient is very, very sick. So, once this huge amount of blood regurgitates into this non-compliant, non-dilated LA, it results in a severe pulmonary edema. It results in severe pulmonary edema. So in a post-MI patient, you auscultate the patient and suddenly the patient is deteriorating, there is lot of crepitations and there is a pan-systolic murmur in the mitral area, then you have to suspect this sudden acute MR secondary to papillary muscle rupture, right? So this is the most important things, these are the most important things about acute MR. So the patient is very sick, the patient develops a acute pulmonary edema and the patient will also have hypotension. Okay, so this is about acute MR. Now when you look at chronic MR, so what happens is that in chronic MR, this has been happening from a long time. So there is some amount of regurgitation back into the LA which is going on from a long time. So initially what happens? Whatever blood regurgitates is pushed back into the aorta. Whatever blood regurgitates is pushed back into the aorta. So nothing happens, but over the course of time as the regurgitation progresses, there can be dilatation of the LA and LV. There can be dilatation of the LA and LV. Okay. So over the course of time, there can be dilatation of the LA and LV up to the point where the MR is compensated. The MR is compensated by the contractility of the heart, right? So initially there will be some amount of regurgitation into the LA. Whatever is pushed in or whatever happens is pushed into the LA is pushed back into the aorta because of the hypercontractile heart. So until the point where it is compensated, once there is decompensation, so the heart compensates by what? Heart is exposed to a chronic state of volume overload. Why is there a chronic state of volume overload? Because whatever blood is pushed back into the LA is coming back to the LV again, and then again it is getting pushed to the aorta. So chronic state of volume overload, it is compensated by dilatation of the LA and LV. Once there is dilatation of the LA and LV, it can happen only to a certain extent, followed by which there can be failure. The LA and LV cannot dilate further, and once there is failure, the cardiac output begins to fall. Also, this chronic volume overload also results in left atrial enlargement and increased left atrial pressure, and this increased left atrial pressure can also cause pulmonary venous congestion and pulmonary edema. There can be pulmonary venous congestion and pulmonary edema. So, what are the most important symptoms which the patient can present? The most common symptom is fatigue. Now we know that in MR there is a chronic volume overload state because of the huge amount of regurgitant blood. So this volume overload will result in what? It results in an increased heart rate which is seen as palpitations. And over the course of time, the patient can develop failure and pulmonary hypertension. Over the course of time, in the later stages, the patient can develop failure and pulmonary hypertension. Another very important thing or concept that you should be understanding is that initially in acute MR, what happens to the ejection fraction? So, in acute MR and in the initial stages of chronic MR, some amount of regurgitant blood goes into the LA, correct? Now, what happens to the end diastolic volume? The end diastolic volume at the end of diastole increases because whatever blood is there in the LA is also going to come back to the LV. So whatever blood which is there in the LA is also going to come back to the LV apart from the blood which was already there at the end of diastole initially. So once the end diastolic volume is increased, what happens to the stroke volume? The stroke volume is given by the formula EDV minus ESV by EDV. The end diastolic volume minus the stroke volume by end diastolic volume. So what happens is that the end diastolic volume is increased in the initial stages of chronic MR as well as severe acute MR. If the end diastolic volume increases, what happens is that the stroke volume is furiously increased. So the stroke volume is furiously increased. Because the end diastolic volume is increased, the stroke volume is furiously increased because of the hypercontractile LV. So this happens in early stages, right? Fine. So now we have understood the hemodynamics of acute MR and chronic MR. So now let us look at the clinical features. You can just recollect now easily. Symptoms are palpitations because of volume overload. They can have fatigue. And over the course of time when there is pulmonary congestion, development of failure, and they can have pulmonary artery hypertension as well. So they can have dyspnea. Okay. So these are the symptoms of mitral regurgitation. Let us look at the signs. So what happens to the pulse? Since this is a volume overload state, what is the type of pulse that you find here? You find a mini collapsing pulse. Mini collapsing or the pseudo collapsing pulse is seen in mitral regurgitation. The blood pressure is usually normal. What happens to the jugular venous pressure? The jugular venous pressure is usually normal, can be elevated if there is LV failure or left ventricular failure. Now, let us come to the apex beat. What happens to the apex beat? What happens to the apex beat? We know that the apex beat is because of the left ventricle or right ventricle enlargement. Here, the left ventricle becomes quite enlarged, right? It becomes quite enlarged. So, the apex is shifted down and out. That means the apex beat becomes shifted down and out. Okay. So, will there be a thrill? Yes, there will be a systolic thrill. There can be a palpable P2 if there is development of pulmonary hypertension, and there can be a parasternal heave. The parasternal heave is because of right ventricular enlargement. There can be a parasternal heave. What is the nature of the apical impulse? This will be a hyperdynamic apical impulse. A hyperdynamic apical impulse is a poorly localized apical impulse in the sense that it can be felt over multiple areas and it is present for less than 2/3 of the systole because of the volume overload state that mitral regurgitation is in. So, there is a hyperdynamic apical impulse. Let us look at the auscultation. What happens to the S1? As we all know, the structure of the valve determines the intensity of S1. So, the S1 is soft. What happens to the split? The split is wide. S3 is definitely present in acute MR only, and usually you do not have a fourth heart sound. Okay. Now we have understood the hemodynamics and clinical features. All of these clinical features are more for chronic mitral regurgitation. All of these clinical features are for chronic mitral regurgitation. Now, how do you differentiate between the acute MR and the chronic MR? So, acute MR is more symptomatic. Patient is much more sicker, unlike chronic MR. Apex beat, will it be shifted in acute MR? No, it will not be. There is no time for any chamber enlargement. Apex beat will be shifted in chronic MR. Will you have an S3 and S4? Yes, you will definitely have it because the MR is into a non-dilated and a non-compliant LA. This high amount of blood is again filling back into a non-dilated LV. So, you can have an S3 and an S4. So, what is the murmur? The murmur is an early systolic murmur. So, what murmur do we see? We see an early systolic murmur. Okay. So, you see an early systolic murmur, but you see a pan-systolic murmur in chronic MR. You see a pan-systolic murmur in chronic MR. So, we will maintain only up to murmur which is seen in acute MR is an early systolic murmur. An early systolic murmur is seen in acute MR and a pan-systolic murmur is seen in chronic MR. because the pressure gradient in chronic MR is maintained throughout the systole, whereas in acute MR the pressure gradient is maintained only in the initial part of the systole. So that is the difference between your acute MR and the chronic MR. Now let us look at the clinical assessment of the severity of the murmur. So the severity of the murmur basically depends on the following things. So if there is a wide split S2, it means that it is already a severe MR. Unlike the MS, the severity of the MR is determined by the intensity of the murmur. The presence of an S3 or the presence of an MDM murmur. So what happens is that whenever there is an MR, you find that there is a pansystolic murmur. Whatever blood regurgitates back into the LA can flow back between the LA and LV, and you can have an MDM murmur as well. So this MDM murmur is what says that the murmur of MR, the MDM murmur is what which says that the MR is severe. Okay, so these are the factors which determine the severity of the mitral regurgitation. Clinically, you can say whether there is MR or no. Okay, so let us just recapitulate. How do you describe the PSM murmur of MR? So the murmur of MR is described as a pansystolic murmur in the apical area, in the mitral area, which radiates to the axilla. It radiates to the axilla and it is best heard with the diaphragm of the stethoscope, with the breath held in expiration and patient in the supine or lateral position. Okay, so that is how you best describe the murmur of MR. Now, can the MR murmur radiate to the base of the heart? Yes, the MR murmur can radiate to the base of the heart, especially if the posterior leaflet is ruptured, it can radiate to the base of the heart. Okay, so that's about all the clinical features of MR. Now, let us look at the investigations. So, what happens to the ECG? In ECG, what happens over the course of time? You can have left ventricular hypertrophy signs, you can have left atrial enlargement, you can have signs of pulmonary hypertension. On the chest X-ray, you can find that there is development of cardiomegaly. There is development of cardiomegaly because of left ventricular hypertrophy. Okay. Now, on the echo, how do you know that there is severe MR? We will be looking at the different parameters. Now, management of acute MR. In acute MR, the patient is very, very sick. If the patient is in severe pulmonary edema, you can give diuretics. Also, you have to give vasodilators like nitrates. But be careful about the blood pressure as well, so that you decrease the afterload and you decrease the MR. Most important definitive step in the management of acute MR is that the patient has to be emergently taken up for surgery. So that's about the management of acute MR. Now let us look at the management of chronic MR. Now let us look at what are the echo parameters which basically help us identify what is a severe MR. So you just remember the numbers 7, 6, 5, 4. Okay, 7, 6, 5, 4. So what is this VC? VC basically refers to the vena contracta. So this is a little bit of a higher level knowledge, but let us try and break it down to more simpler things. So vena contracta basically refers to the middle area of the regurgitant jet, right? So the narrowest portion of the regurgitant jet is what we call as the vena contracta. If the vena contracta is more than 0.7, we call it as the severe MR. Then we look at the regurgitant volume or the volume of regurgitant blood. If the volume of regurgitant blood is more than 60 ml, then this is a severe MR. Then we look at the regurgitant fraction. What is the meaning of regurgitant fraction? How much percentage of the blood that is ejected, right? How much percentage of blood that is ejected is coming back to the regurgitation, right? Is it 50%? Is it 60%? So that is your regurgitant fraction. Regurgitant fraction more than 50% is severe MR. So the effective regurgitant orifice is nothing but the area of the regurgitant jet is taken as the effective regurgitant orifice. And this, if it is more than 0.4 centimeter square, we call it the severe MR. So just remember 7654 and remember, try to understand the basic, what is vena contracta, what is the regurgitant volume, regurgitant fraction. Basically, what we are trying to see is, if the regurgitation is more, the MR is more severe. Okay, now we had already learned about the staging of MS. So similarly, there is a staging of MR as well. So stage A is at risk of MR. Stage B is progressive MR. Stage C is asymptomatic severe MR. And stage D is symptomatic severe MR. So when do you want to do a valve replacement or a valve repair? In stage D, regardless of the LV function, you will have to do a mitral valve surgery. In stage C, where the patient is asymptomatic, if there is LV systolic dysfunction, EF is less than 60%, then you go ahead and do a surgery. In stage C, if there is normal LV function and we feel that there is progressive increase in the LV size from the past 3 studies, or you feel that a replacement will help the patient, then you go ahead and repair. Okay. Now, if there is a high risk of complications, a high risk of surgery, and if the anatomy is favorable for a transcatheter approach, then we can do a transcatheter H to H mitral valve repair. So what happens is that there is a device that we use which is called as the Mitral clip. Okay, this is what we call as the Mitral clip, and what you can do is that this is your mitral valve which is regurgitating and you clip it. So once you clip it, what happens is that the effective surface area decreases and the regurgitation comes down. So this can be used only in selected cases. Okay. Apart from this surgical management of MR, you also have to remember that we will have to give some medical treatment as well. If the patient is quite symptomatic, there is a lot of edema, then you can give a trial of diuretics. Also, because in MR you can have a lot of palpitations, you can give beta blockers. Okay. And drugs which control the hypertension such as ACE inhibitors and ARB can also be used in the management of mitral regurgitation. But the definitive management of mitral regurgitation is your surgical mitral repair. These medical managements are used in different etiologies. In secondary MR, maybe like in patients with heart failure with MR, these drugs can be useful. But if the MR is due to other etiologies, then surgical management is the definitive treatment. Okay, so that brings us to the end of our discussion on mitral regurgitation. Thank you.